Hi, my name is Daniel Rubin, and I'm a neurologist at the Brigham and Women's Hospital in Boston, Massachusetts. Today, I will be presenting to you the results from our new study, recently published in Brain, characterizing the clinical and diagnostic features of neurotoxicity associated with chimeric antigen receptor T-cell therapy.
CAR T-cells are produced by collecting the patient's own T-cells and engineer them to direct an immunologic attack against the patient's specific form of malignancy. Traditionally, patients with relapsed or refractory hematologic cancers have poor prognosis, as second- and third-line therapies rarely achieve durable rates of remission. In contrast, CAR T-cells have achieved remission rates of 40 to 90% in some trials of patients with relapsed and refractory disease.
Unlike CRS, the clinical features and mechanisms underlying CAR T-cell associated neurologic toxicity are poorly characterized. While many patients experience only mild confusion, others experience severe focal neurologic deficits, and in some cases even fulminant cerebral edema and death. Moreover, it is difficult to predict which patients will experience severe neurotoxicity, and our current treatments for CAR T-cell associated neurotoxicity are of limited efficacy.
In the current study, we cataloged and characterized the neurologic signs and symptoms, laboratory studies, and results of imaging and other neurodiagnostic studies on all patients receiving CAR T-cell therapy at our institution over a period of more than 3 years, from April 2015 through September 2018. In total, we followed 100 patients that received CAR T-cell therapy. The most common indication for treatment in our cohort was relapsed or refractory lymphoma. A smaller number of patients were treated for leukemia and myeloma, and 2 patients were treated for sarcoma. All patients were adults over the age of 21. 39% of patients were female. At least one neurologic symptom was observed in 77 patients, and CTCAE grade 1 or higher neurotoxicity was observed in 48 cases. Neurotoxicity most commonly started on post-treatment day 6, peaked on post-treatment day 8, and persisted for 8.5 days. Neurotoxicity was more likely to occur and more likely to be severe in patients that suffered early CRS, and was associated with greater baseline and peak serum C-reactive protein.
The most common neurologic symptom observed was encephalopathy, followed by headache and tremor. Many patients developed focal neurologic symptoms, including aphasia, focal weakness, numbness, apraxia, and allodynia. Only one clinical seizure occurred in our study. Many of the symptoms observed, in particular the CAR T-cell associated encephalopathy, aphasia, and tremor, had a stereotypical quality and progression that we describe in greater detail in the paper. Importantly, in almost all cases, neurologic symptoms were transient in nature, and patients recovered without any long-term neurologic sequelae. Despite the frequent occurrence of focal neurologic deficits, structural neurologic injury was rarely identified. 99 CT scans were performed on 44 patients, and 29 patients underwent MRI of the brain. From these studies, only 2 ischemic strokes and 2 intracranial hemorrhages were identified. In contrast, functional neurodiagnostic studies, including EEG, transcranial Doppler ultrasound, and FDG PET, frequently identified abnormalities in patients experiencing neurotoxicity. 36 patients underwent EEG for evaluation of neurotoxicity, which was abnormal in 28 cases. Interestingly, focal neurologic symptoms were often seen in patients with focal EEG abnormalities, such as aphasia, weakness, and visual scotoma. 6 patients with neurotoxicity and abnormal EEG underwent FDG PET scan, which surprisingly revealed cortical hypometabolism in the regions of abnormal EEG activity. Transcranial Doppler ultrasound also demonstrated increased flow velocities in patients experiencing focal versus non-focal deficits. Previous research has suggested a potential role of a CAR T-cell associated autoimmune encephalitis as a potential cause for neurologic symptoms. However, in our cohort, there was limited evidence of CNS inflammation. CSF samples were obtained from 14 patients and were largely bland. Furthermore, a pathologic specimen from the brain of a patient that died with severe neurotoxicity revealed no evidence of widespread brain inflammation, but it did demonstrate several interesting findings. H&E staining and fibrin staining showed perivascular extravasation of acellular proteinaceous substance, and there was marked plasmatodendrosis, signifying retraction of astrocyte foot processes and widespread blood-brain barrier dysfunction. These changes were absent from the brain of a patient that died from disease progression after severe CRS with no evidence of neurotoxicity. Altogether, these findings and the observation that neurotoxicity typically followed earlier CRS suggest that blood-brain barrier dysfunction, perhaps triggered by widespread endothelial activation resulting from cytokine release syndrome, may underlie the neurologic symptoms we observed. In conclusion, We demonstrate in this study the breadth and qualitative features of CAR T-cell associated neurotoxicity as a syndrome of both generalized and focal neurologic dysfunction. This study highlights the importance of functional studies of neurologic dysfunction, including EEG, FDG PET, and transcranial Doppler ultrasound, in characterizing neurotoxicity, and emphasizes several clinical and laboratory predictors of severe neurotoxicity.
This work represents the product for unique collaboration and ongoing partnership between the field of medical oncology at the Dana-Farber Cancer Institute and the divisions of neurocritical care at Brigham and Women's Hospital. Thank you for listening, and please read our paper to learn more.